Hi, students. So I realized that I did not put what's coming up here on the test for the clinical psychology test, but it'll be 27 multiple choice, one FRQ with 7 terms. 3 of those terms will be from previous chapters, so very familiar of all the other tests that we've taken of a typical a typical unit test. So let's get into defining disorders. It's a significant disturbance in thought, emotion, or behavior. So, in order to define someone with a disorder, it needs to be maladaptive, which means it interferes with day to day life. I've been pretty open with you about my own phobia. Probably not really maladaptive for me because I've learned to overcome and adapt to ways where I don't have to deal with that. Therefore, I don't kind of have that label and that diagnosis. The medical model is understanding that disorders can be treated with medication, hospitalization, or therapy. This is kind of the first start of looking at people as people with conditions, and we weren't just looking at people as immoral or a bad character or evil, possessed, things like that. And we really looked at the people and how they can be treated, how the disorder can be treated. So the types of approaches, now you're familiar with all of these, but keep in mind when we're talking about clinical psychology, how the different approaches depends on how we interpret and think about the way that they're going to be treated and the way we're going to really analyze it. So the biological approach is going to use the medical model to understand the brain and treat with prescription. Can you see that? It says like R, capital R, lowercase x. That means prescription medication or hospitalization. In the next chapter, we'll really look especially at the biological and the cognitive approach. And it tends to be more on the medication side, the way we often treat cases. The psychodynamic approach, this is, remember, the Freudian understanding. This is how we understand that the unconscious conflict, often stemming back from the past, motivates our behavior or even like our thoughts and things. Now, we don't really consciously think about it. It's that unconscious conflict within us. The cognitive approach, this is the perception of how we think and what we believe others think of us. So this kind of interpretation, and again, the way we think, cognition, think. And so if something happens or somebody says something, in our minds, we interpret it in a certain way. The sociocultural approach, this is when there are cultural circumstances or in our environment and how that influences behavior, thoughts, and attitudes. So again, we talked about in class here in the Upper Midwest, the way we look at medical disorder or mental disorders and the therapy and treatment of them. It's probably very different than in other areas of the United States, but that's because of our environment around here, the way people think around here and behave. And then the behavioral approach. Now, the behavioral approach is only looking at observable current behavior. So, for instance, we'll talk about PTSD here in a moment. Somebody who's a behaviorist who's treating PTSD is really not going to talk about or really not going to worry about, okay, well, what's the behavior that has caused some of this anxiety, some of this post-traumatic stress disorder. Let's just talk about your current behaviors and really only going forward, moving on from the observable behaviors. The DSM, this is the Diagnostic and Statistic Manual of Mental Disorders. We are in the 5th edition now. Each edition is getting longer and longer. And basically, the DSM helps us categorize and give criteria to mental disorders. Typically, the number one thing is the number of symptoms. That's how we diagnose and the criteria that we need to diagnose mental disorders. Age is often an important factor. Time, how long an individual has been experiencing symptoms or whatever it might be. So, do you remember when we talked about schizophrenia? Well, if it's a matter of acute, it could be like a day or maybe even just a very short, not even a week, a couple of episodes. Or if it's chronic onset, the time could be actually as short as 6 months. So time is an important factor in the criteria of diagnosis. And then grouping, the type of disorder it might be. If it's anxiety disorders, if it's neurological disorders, if it's personality disorders, all those different types. Rosenhan's study in stigma. Now, this was a really important study to understand how diagnostic labels show patients can carry a stigma even after recovery or normalcy. So oftentimes an individual will seek and really want to have a diagnosis, which helps them on the road to recovery. However, oftentimes then that stigma, that label can carry with them for maybe even decades after they've really reached a point of being in good mental health. And sometimes it's difficult to kind of shed that label. It feels like this kind of albatross, this weight around us that is difficult to get rid of. And so it's important to understand that diagnostic labels are powerful on both sides of the coin. Comorbidity. This is when there's a co-occurrence of two or more disorders or diseases. If you are a practitioner or involved in any way in clinical psychology, understanding how mental disorders or diseases affect one another is really important to understand how to balance patient care. If you yourself are find yourself having comorbid factors, you have to decide with your doctor, or your doctor has to really sit down with you and talk about what's most important to you, your mental health, or maybe feeling having some sense of relief in other aspects of your health. Anxiety disorders. Let's talk about GAD, generalized anxiety disorder. This is characterized by being jittery, kind of agitated and on edge, having sleeping problems, typically a lack of sleep. It's hard to ease your brain and kind of let your brain slow down. It's very hard to pinpoint, however, because there's nothing that really sets off this anxiety, nothing necessarily one thing that makes us jittery. So it's difficult to assess what it is. And it often is in women. Panic disorders. This is kind of like that unpredictable, we talked about an anxiety tornado. This unpredictability, it's characterized by having a shortness of breath, a choking feeling kind of dizzy and like you can't think straight. It's fairly brief though. And again, time is really important, right? So when I say brief, oftentimes panic attacks, this panic disorder illness, they only last for maybe 3 or 4 minutes. But if you feel like you are choking for 3 minutes, that's a long time, right? So I would feel very powerless against my panic disorder, even though it's a brief amount of time, if I have this shortness of breath and sensation that I can't breathe for that many minutes. Phobias. Phobias are this irrational fear, but typically they are specific phobias. If we're talking about just a general anxiety or fear of something, it's more generalized anxiety. And so typically phobias are something specific, like a fear of an animal or a natural disaster or a storm or something like that. Heights are enclosed spaces. These are all common phobias. Social anxiety disorder. This is when there's extreme shyness or a fear of being singled out or humiliated in public. Um, it's about as simple and straightforward as that. People just will really seek to prevent and shelter themselves from that uh, fear of humiliation. Agoraphobia is a fear of large crowds, especially in open spaces. When there's no really way for a person to escape, that feels very um, out of control. PTSD stands for post traumatic stress disorder. It can be a result of abuse, tragic events, natural disasters, but PTSD, and we used to call it like shell shock in wartime situations, but we know it's not just that anymore. But it can lead to things like depressions, phobias, anxiety, which, we talked about this word comorbidity. We treat depression differently than we treat, say, phobias or anxiety. And so understanding what maybe takes precedence, is it the depression or is it the anxiety for the person? PTSD is categorized as an anxiety disorder, but oftentimes people are very depressed as an underlying disorder resulting from that tragic event or that abuse, whatever it might be. It's characterized especially by nightmares, having flashbacks of the events that they can't really unsee or get out of their mind. However, the beauty of post-traumatic stress disorder is that we see a lot of post-traumatic growth shows survivor resilience, meaning people are able to, especially through therapy, especially through talk therapy, overcome the PTSD, their trauma, and really grow from it and learn from it and kind of come out on the other side knowing, not that the trauma is good, but knowing the trauma contributed something about themselves in their lives and maybe made them a stronger person, of a more kind of self-actualization. Who am I? Why am I here? And who am I really in this world? OCD is the last anxiety disorder I want to talk about. Obsessive compulsive disorder. This is characterized by unwanted repetitive thoughts, which are the obsessions. You keep thinking about it and you can't stop thinking about it. Like it just keeps playing over and over and over in your mind. Or actions, those are the compulsions. And those are, the things that we're doing. We're counters, we're checkers, we're hoarders, things like that. And that's often maladaptive. When we talk about obsessive compulsive personality disorder, that's more of a need in our own personal life for some sort of neatness and order, whereas, and not necessarily maladaptive. OCD is oftentimes very maladaptive. Mood disorders. I want to talk about 3 of them. I want to talk about depression in general. It is the most diagnosed mental disorder in the United States. Depression ranges from mild to major MDD, major depressive disorder. It can be treated with prescriptions, therapy, but also lifestyle changes. Now, we're going to talk again about treatment a lot in the next chapter, but I do want you to understand that because it's the most diagnosed in the United States, we need to understand that this is a kind of a multi-frontal attack on how to best handle depression. And we look at it differently in the United States than we do, say, in other countries, whereas in Europe, they definitely look at it more in lifestyle changes, especially for mild or moderate depression. Whereas here in the United States, even mild depression, we look at it probably more from the biological standpoint, using the medical model, using, for instance, medication. Major depression disorder. So it's mostly characterized, and time is a really important factor, as 2 weeks of having, they say, at least 5 symptoms. Things like a depressed mood most of the time, a loss of energy, difficulty sleeping, little enjoyment, no enjoyment, or distraction even in things that you once had before. Now, one thing, and you can see this over on the side, I want you to understand that major depressive disorder is not grief, but it very much can overlap. So let's say in my life, I have something very tragic that happens and somebody very close to me dies. Grief is a natural response, but I can be grieving for a very long time, right? Like maybe I'm grieving for 6 months. Well, that for sure, kind of takes up the time factor of more than 2 weeks. Could I be in a depressed mood most of the time, have a loss of energy, difficulty sleeping, no enjoyment or distractions in the things as I once did before, because this death was really so impactful to me? So I do want you to understand that, again, having a diagnostic label is important, but understanding maybe this is, we call it stages of grief, maybe this is a stage of grief that people have to work through. And there, once again, is it more of perhaps I should just talk to somebody for a while in talk therapy, or maybe have some lifestyle changes rather than maybe starting on a medication regimen or something. But if I can't get out of my funk, if I can't really feel like I ever have any energy to do things, maybe prescription therapy, prescription medication is the right choice. Bipolar disorder. I don't really want to get into the specifics of the different categories of bipolar, but I do want you to know in general, moods range usually from a depressed mood, very severe depression, to manic, this kind of manic state where it's characterized by being hyperactive, very optimistic, oftentimes very creative in their work or what they do. Personality disorders. Let's first talk about DID. That's dissociative identity disorder. It used to be called multiple personality disorders. Multiple personalities are separated from the self and actually each other. Each of them are very distinct, often personalities. They're very powerful. They can take over. And it's often due to repressed memories. So we develop this type of amnesia, this block in memory, to block out hurtful memories as a defense mechanism, typically because of that repressed event or something that happened in our lives before. Antisocial personality disorder. This is characterized by a lack of conscience. That's probably first and foremost. Very little regret. There's no remorse for the things that we do bad. People are really ruthless. They're very clever and manipulative. It's often men. Now, it doesn't have to be men, but generally it's more men than women who are characterized by or diagnosed with antisocial personality disorder. Histrionic personality disorder is characterized by impulsive behavior, dramatic behavior to seek attention. I don't have it on here, but that's often women who are diagnosed with histrionic personality disorder. Can you cross off paranoid personality disorder and put in narcissistic? I made a change after I printed the review. So narcissistic personality disorder is characterized by a high sense of self-importance. Like that's first and foremost. People think that really everything is centered on them. They have this inflated ego. Remember when we talked about an ego? There's a need for admiration. Everybody has to like them and really actually probably even give them attention, although I don't want to use necessarily the word attention because that makes you think histrionic. It's an inability to take criticism or rejection. The narcissist is never wrong. They don't like to be told to how to do something or that they did something incorrectly. And it's often men. And let's talk about schizophrenia then. Schizophrenia, remember, is a brain disease. It's the most studied. We probably put more money and energy into Alzheimer's, but schizophrenia is the one that we still know very little about, actually, and so it's the most studied brain disease. It's a split from reality. That's what schizo means, split. So let's talk about positive symptoms and negative symptoms of schizophrenia. Now remember, I have there in the margin, positive and negative is not good and bad. It's something added or subtracted. So positive symptoms of schizophrenia are things like hallucinations. Those are perceptions, like false perceptions. When we watched the Anderson Cooper simulation, he was having the perception, the auditory perception. He was hearing voices. Delusions are beliefs, typically these false beliefs that you can do something, that somebody's, it's often like paranoia. You believe somebody's following you or wants to kill you or poisoning you. Negative symptoms of schizophrenia are things like flat affect, where we have no facial expression. Catatonic is when there's no movement. We're just kind of rigid and there's a lack of any body movement. Let's talk about the onset. If it's acute onset, it means the symptoms come on very fast. And I mentioned this earlier. When I talk fast, I'm talking like it doesn't happen and then it happens like you're noticing some of these symptoms within a couple of days. Kind of depending on the age, well, I don't want to get into that, but kind of depending on the age tells us a different kind of schizophrenia. Type 2, we won't get into all of that. But if symptoms are coming on very fast, it's acute onset, and there are better results or more effective results in treatment. If it's chronic onset, which I think is 6 months or more, it's the symptoms come on more slowly, but the results are not as good. There's worse results in treatment. The treatment is actually less effective. So if you know someone or your loved one, or maybe even you can tell in yourself, you are experiencing or you see somebody experiencing these kind of odd behaviors or kind of weird expressions or inappropriate behaviors, the faster you can seek medical attention, the better it is. Dopamine. We know that the biggest key to understanding schizophrenia is that there's an excess of dopamine receptors which cause the psychoses, these symptoms, like paranoia or hallucinations. And so schizophrenia for sure needs to use the medical model. Antipsychotic drugs are the first line of defense. Talk therapy doesn't really work. Hospitalization can actually be very effective in treating treating the symptoms of psychoses. So the dopamine is really an important part of it. I want to talk a little bit about epigenetics, and it is tightly related to schizophrenia. So when we talk about epigenetics, remember how I said like one hand doesn't clap alone. You don't have tea unless you have hot water and the tea, right? The bag of tea. You have to put those together though. So when we talk about epigenetics, it's that how behavior and the environment can cause changes in the way genes work. So it's not a change in your DNA, it's a change in the sequencing of the DNA, the way your genes kind of operate, and that is because of your environment. So for instance, like a virus or exposure to nicotine or nutrition, these are all epigenetic factors, and in the case of schizophrenia, that can really have a big impact. And so our environment definitely plays a key in the way our genes work. But it typically, it's not like if we have bad nutrition or we are smokers that we're going to develop a mental disorder like schizophrenia. It doesn't work like that. But if there are a pregenetic disposition, and on top of it, then we have these factors, then it can result in perhaps things like a mental disorder like schizophrenia. And then finally, kind of piggybacking off that is the Diathis stress model. This was the peanut butter stress test, remember? This is when we have a predisposition to a predisposition to a medical disorder, a mental disorder. So the psychological well-being can be triggered by stressful events or responses. So let's say that, we have these pre-genetic disposition to, let's say depression, because it's so common, to depression. Well, then there are these stressful events. Does it mean that I'm going to develop depression because of my genetic predisposition and stressful events that happen in my life? No. Does it mean that the stronger the correlation, the more we have to be like, can one happen because of another? So when we talk about the Diathis stress model, we look at the psychological well-being and how it can be triggered by these stressful events. All right, so that's it. If you have questions, please find me, send me an email, or stop in and talk to me, and be ready for the test tomorrow. Talk to you later. Bye.